welcome to all of you. I hope more will join us. Welcome to our first EUROPREV webinar from 2025. Before we start, we have a very distinguished guest now for our EUROPREV webinar, Professor Michael Bretthauer, professor in medicine at the Oslo University, also gastroenterologist. And he will talk to us about prevention and most especially screening of colorectal cancer. But before we launch into the webinar, I would like to make two announcements. The first one is to invite you all to our EUROPREV forum in 26 and 27 March 2026. You can submit abstracts if you would like to participate. We have 4 topics: sustainable and safe prevention, reducing inequity as a form of prevention, the role of the family doctor in prevention, and prevention in medical and specialty training. And the second announcement is to invite you all for our next webinar, which will be on the 19th of November, hopefully with less technical issues. And this webinar will be about screening for atrial fibrillation. So also two very distinguished guests as speakers, Dr. Christopher Bjerrehaze and Professor Dr. John Brandt Broderson, who will discuss this rather intriguing topic, which is important for all of us in general practice and primary care. And now I would like to give the floor to Professor Bretthauer. I hope you will be able to share the screen.
Yes, thank you.
I will stop sharing, yes.
Let me see if I can bring it up here. Can you see the slides now?
Perfect, yes. Not yet in presenter mode. I don't know if you would prefer that or not. Okay.
Now they're in presenter mode, right?
Yes, indeed.
Yes. Well, thank you so much, Valda, for the nice introduction, and thanks for the invitation. Good evening to everybody. So I will tonight address and hopefully discuss with you the topic of colorectal cancer screening and prevention, and the focus is really on screening and not prevention in the sense of drug prevention or lifestyle prevention. We can discuss that as well at the end if you like, but the focus here is on screening interventions. As Valda said, I am a gastroenterologist. I work at the Department of Transplantation Medicine at Oslo University Hospital here in Oslo. But my main job is as a professor at the medical school where I teach and do research. Also in another role, I'm an associate editor of Annals of Internal Medicine in the United States.
Okay, Michael, I'm sorry. I'm sorry I have to stop you. I get a message that not all participants can see the slides. I don't know if this is for everyone or...
But you can see them?
No,
Val?
I see them.
Okay,
no,
yeah, okay.
I know it's okay.
Okay, thank you.
Okay. Great.
Sorry for interrupting.
No problem, no problem. I cannot see the chat right now, so if there are questions in the chat, Verla, can you please track them and either shout out if you want me to address them while I'm going, or we can collect them at the end of the talk.
Yes, will do. Yeah.
So here are my disclosures. Okay, so let's start with what you put up as the teaser for tonight's session. You say on your website that colorectal cancer screening saves lives, but you wonder what the most effective method for such screening is, how often you should do it, and what age you start, and maybe also to stop, and what we should tell our patients. And I will try to address all that. And I put out the first of this sentence in bold because that's the only thing here which is a statement. A statement, and everything else is with a question mark, but the statement here is that colorectal cancer saves lives. And I'm not quite sure if it does, so I will address that also. We'll come back to that in about 20 or 30 minutes. So first, a little bit of background, and I think it is important for all of you to understand that when we talk about cancer screening, we talk about very different things. And for me, at least, it is helpful to divide common cancer screening tests into two different principles. On the one hand side, there is what I call preventive screening. These screening tests remove benign precursors of cancer with the goal then to reduce the incidence, so the risk of getting cancer, and thereby also the risk of cancer mortality, because it is evident that you can only die from cancer when you first get the cancer. So people who do not get cancer do not die from cancer. That's quite logic, but sometimes forgotten. There's only 2 of all the screening tests that you prescribe or even do in your GP practice, and that I do, only 2 of all of them, and I will list them for you in a second, which are preventive screening tests. And one is cervical cancer screening, either by pap smear or HPV testing, and the other is endoscopic screening for colorectal cancer. For example, today mostly by colonoscopy in some areas, and previously by sigmoidoscopy, so half a colonoscopy. Only those 2 are preventive screening tests that aim at finding and removing benign precursors of cancer. All other tests, PSA testing for prostate cancer, mammography for breast cancer, melanoma screening, lung cancer screening, and screening with fecal testing for colorectal cancer are early detection screening tests. Their goal is to detect invasive cancer early. These 10 tests cannot reliably detect precursors of cancer, and therefore they cannot reduce cancer incidence. They cannot reduce the risk of getting cancer. They can, if they work well, reduce the death rate of cancer, but not the incidence. In fact, many of these tests, as many of you know, increase cancer incidence by overdiagnosis. So very different concepts, and it's important that you understand that. Colorectal cancer screening is in many ways an outlier of all the cancer screening areas that we have. Ailem, could you mute yourself, please? Thank you. For most all of the other cancers that we screen for, there's one test that is predominantly used. So for breast cancer, it's usually mammography. For prostate, it's PSA. For lung cancer, for smokers, it's CT. And for cervical cancer, it has been pap smear now. In the future, it's HPV. For colorectal, and this makes it exciting for somebody like me who does this for a living, and maybe confusing for you who prescribes all these tests. There are many tests on the market and many tests that people can do or order or are recommended in different countries. So there's fecal testing, old-fashioned FOBT, fecal occult blood testing, or the newer version of it, which is called FIT, so fecal immunochemical testing. Both of these they're very similar. It's just the method of detection which is different, but both measure hemoglobin in the feces. Very simple tests. Then there are newer ones which combine hemoglobin tests with fecal DNA, RNA, or other genetic markers, predominantly used in the United States. Then there are endoscopy tests, as I told you, colonoscopy, sigmoidoscopy, now mainly colonoscopy. And then there is CT colonography, and then there's capsule endoscopy. So many tests. But as the teaser showed you, not only do we have different tests, but we do the tests differently with regard to age and gender, how often we offer them or recommend them, or what cutoff or threshold have for what we call a positive test. And we also can do combinations of different tests at the same time or at different times in life. So it all gets rather complicated as compared to breast cancer screening or prostate cancer screening, where there's only one test. And of course, after screening, maybe the trouble even starts, because then you find polyps and you have to wonder, okay, what do you do with the patients? How often should they come back? What kind of tests should they have after they have removed a polyp, etc.? This landscape is complicated and difficult, and it is evolving. And one of the consequences of this, I think, is that different guidelines in the world about colorectal cancer screening recommend very different things. For example, here on top of the slide, the United States Preventive Services Task Force, which is the #1 guideline maker for preventive services, not only for colorectal, but also others in the US, they recommend any of the 6 tests which are here on the right side. While the International Agency for Research in Cancer, which is the WHO's health research organization in Lyon, France, only recommends 3 tests and not 6. Is there a possibility to mute people from my side? No, I don't think so. There's somebody talking. So if you could mute you, thank you.
Okay, can everybody check if the microphone is muted?
So I'm trying to help you with that.
Okay, thank you.
Thank you.
I mute people.
So different guideline makers propose different tests at different intervals and with a different strengths of the recommendation. And I think this is a reflection of many different tests and evolving evidence. So it's confused. If it's confusing for you, it's not only confusing for you, it's confusing for many people. So I will now try to answer how we find the best test for a person or a patient. But first, let me come back to the 2 concepts just for another slide, the prevention screening and the early detection screening concept. Here I illustrate this by the 2 tests that we are going to talk about most this evening. The 2 colorectal cancer screening tests that are mostly used in Europe and in the world: colonoscopy and FIT, so fecal immunochemical testing, hemoglobin measurement in the feces. Colonoscopy is on the left-hand side. It is a prevention screening test. It reduces, if it works, the risk of getting cancer and therefore the risk of dying from it, because as I told you, only those who get it die from it. It is a test which does not need to be repeated often. And when you are done with it, you are done. There's no second test. You do the colonoscopy. My friends and colleagues remove any polyps that may be there, and you are done for another at least 10 years, maybe lifetime. However, it is invasive. It requires bowel preparation, and it is expensive, either for the patient or the healthcare system. On the other side, you have FIT. It is an early detection test. It is not good in detecting adenomas, so polyps, precursors. But if it works, and we will see at the numbers, it may reduce the risk of dying from colorectal cancer, not of getting it. It must be repeated often because it's not very good as a single round, mostly every other year. In the US, some say every year. There must be a colonoscopy for the people who are positive. But it is non-invasive and it is cheap. It can be done at home. So there's pros and cons, and these 2 tests are in the 2 different concepts. Just to mention for you, in case you're wondering, of course, FIT screening can be used as a prevention test. So how is this possible? Well, one can lower the threshold For example, if one lowers the threshold to 0 hemoglobin in the feces, and we can do that because we can get the actual numbers out from the test results. So usual threshold for colorectal cancer screening programs would be 20 or 30 or 15. The UK has 100. If it goes down to 0, so all people who have above 0 hemoglobin in their feces are positive, then you will get a positivity rate of 50%, and half of the people will go to colonoscopy, and there will be a lot of polyps removed. Then you turn a FIT screening program into a prevention test program. It's possible. But however, you will be very close to a colonoscopy program because for one round, 50% of people will go to colonoscopy. If you then imagine you do this every other year, after about 10 years, almost everybody will have a positive test and go to colonoscopy. But one can do that. I don't know that anybody does it, but it's doable. So how do we find the best test? I think it's important to remind ourselves that we have to ask the good questions. And interestingly, in medicine, this is not so often applied. It's very simple, but it's not often applied. We have to ask 4 questions. Number 1 is, what is the risk of the disease we want to prevent in that person who sits in front of us? And there are calculators for that. It's easy to find out. This risk should be termed in absolute numbers. So I give you an example. If you have a patient who has hypertension, you would say, well, Mr. Olson, if you, in your GP practice, if you take this drug to reduce your blood pressure, you will reduce the rate or the risk of getting a heart attack by 50%. That is not good patient communication, because what you really should tell the person is what the risk is for getting a heart attack. And then you can subtract from that risk what the pill gives you in effect. So you may say, well, Mr. Olson, your risk of getting a heart attack with your hypertension for the next 10 years is 2%. If you take this pill, you can reduce it to 1%. It's exactly the same numbers, but it's much more informative. Unfortunately, we don't do that very often, but we should. So I want you from now on after this talk to tell the person or to calculate the absolute risk of colorectal cancer and then subtract the benefit he or she can get from screening for incidence of the disease and for death of the disease. And I will show you the numbers in a minute. And then I would tell that person what the harms of screening are. For example, the adverse events and the complications. Here, for colorectal, it would typically be perforation and bleeding. And then the burden. What does it mean to have a colonoscopy? How much does it cost? What is the bowel prep? How long does it take? Etc. The practical issues. With these 4 things, if you approach these 4, and that can be done in 20 seconds, you have a good patient communication. We don't do that very often, unfortunately. And then you have to engage in something that you know and do very well as GPs. You talk with the patient about his or her values and preferences, either as an individual doctor or if you have another role in society. And if you have a society role, and this is a tougher one than the values and preferences, you have to discuss thresholds. In other words, how large should a risk be to do something about it? Is it 1% or 3% or 10% or 50% or 90% risk of a heart attack or colorectal cancer in the next 10 years or 15 years? That's a tough one. But without asking these questions, it's very difficult to give recommendations. So we're applying the benefits, we're applying the harms, and they're coming from the literature. And when we are adding in the values and preferences of a patient, and we're discussing thresholds, what to do when, or not to do anything if the risk is too low. For those of you who would like to read more, there's only, and this is symptomatic, I think, there's only one guideline of all the colorectal cancer screening guidelines out there in the world, and there are many. I showed you two of them a couple of slides ago. Here's the third one. Only this one, published in the BMJ in 2019, that does all this, what I just explained to you. None of the others does that. They often talk in relative numbers, and that's not helpful. So if you would like to have a good guideline which explains all this, look up this one. Here, you can first estimate the risk by, for example, using this Q cancer calculator down there at the bottom, where people can just put in age and gender and smoking and stuff, and then get a 15-year risk or a 10-year risk or a 20-year risk you can choose. That's where you start. And then you look at the option of your tests, for example, here, FIT every year or every other year, and sigmoidoscopy and colonoscopy. And of course, one option is to do nothing. And then there are these nice spider diagrams with the starting risk up on top, and then the reduction. So it goes, for example, if you look at the upper left corner, there is, for a person with a 2% risk within 15 years, they have a mortality risk per 1,000 people of 6. That means 0.6% if you do nothing. If you do FIT every year, you can reduce it to 3. So from 0.6% to 0.3. And you can do this for different scenarios and different risks and for the different screening tests. It's very simple, and it's very easy to explain this to patients. Now, these data I have to mention. This is a 2019 publication. These data, so what's in those boxes or in those circles, they come from modeling, because up until that time, there was very little trial data available, at least for some of the tests. Luckily, after this publication, there are trial data for many of these, and I will show them to you in a minute. Then you do the harms, and then you describe the burdens. For example, here, how long does it take to do the tests? What do you do to prepare? What happens during the process? Is it painful? Do you get drugs? And what happens afterwards? Simple advice for practical things that patients should know. So before we go then to the newest high quality evidence for these numbers that I just showed you, so we're going to update these together, I just want to mention to you that this is, as in medicine in general, an evolving topic. So things change over time. And there is mainly two things I would like to highlight here for colorectal cancer screening, which do change and which have changed just recently, just the last 2 or 3 years, which will affect the benefits and the harms of these tests. Number one is that we have known this for about 8 or 10 years, that we, the people who do colonoscopies, some of us are very good in finding these precursors, the polyps that we are looking for to reduce the cancer risk, and some others are not so good. So here, for example, this is a publication in JAMA, US data, where endoscopists, people like me who do this every day, are divided by the rates of polyps they find during colonoscopy. And these patients that these doctors having, they are the same. They should have the same risk, or they should have the same number of polyps that are found. But as you can see by these different curves, there are people who are very good in finding these polyps, and then there are other people, doctors, people like me, who are not finding the polyps. And the variation is quite large. And here in this slide, you see that the people who find more polyps, these patients after the colonoscopy, and here followed for 6 years, they have a lower risk of getting cancer. It's quite logical, because the whole thing, as I told you, is to prevent cancer by finding polyps and taking them away. If you don't find all polyps, the risk of cancer is higher than it should be. And here we show, or the American colleagues have shown, that this is indeed a problem. If you are a patient who is scoped by somebody who is not so good in finding polyps, you will have a higher risk of getting cancer after a colonoscopy. And this has been updated. Here you can get the impression that there's a linear association between the ability of finding polyps and the cancer risk. We updated this earlier this year, also in JAMA, with a Polish data set that showed that if you are somebody like me, an endoscopist, who finds polyps in more than 25% of patients, that's the blue vertical line there, then you are good. Above that, there's not much more benefit. But if you are somebody like me who finds less than 25%, then the risk of cancer for the patients goes up. In other words, we who do this for a living, because for you as GPs, it's hard to know, well, okay, Michael, is he good? Is he above or below 25%? Or the people at your hospital that you refer to, you don't know that. So it's up to us to set up quality programs that make sure that nobody's below 25%. That's our problem and our problem to solve. But the problem exists in many countries, if not in all countries. The other thing which is developing is AI. We have two AI things in endoscopy that we are currently introducing. Now, number one, we call it CAD-E, left-hand side. It's those small boxes that you see here, small green box that points the endoscopist to a polyp. And this is especially important for those of us who are not so good in finding polyps. And as I just told you, there are some who are trying but not seeing them as well. This AI tool can help them because it puts boxes on the screen around the polyps. Here is one, take it out, which helps us with that quality problem that we are having. The other, on the other side, the other AI tool, which is more in development, CAD-E is introduced currently, CAD-X is not introduced yet, will be in some years, is to find out right after you have that box, what kind of polyp is this? Is this already a cancer? Or is it a precursor of cancer? Or is it just an hyperplastic polyp which will never grow into cancer? Because we have these as well. This is now very hard to know when you just scope and see a polyp. That's why we remove all the polyps today. But with this new tool, we I think we will, be able to know, the computer tells us, oh, this is a polyp that you can just leave in because it's not dangerous. And this one you have to take out. Why is it important? Well, it saves us time. It saves money because we don't need to take out all, and it saves time also for the pathologists who need to look at all these polyps afterwards. So coming back to the new data. And first I want to tell you what the old data showed. And there is a lot of, well, you showed it in your teaser. You said colorectal cancer screening saved lives. So there's a lot of optimism. Some may say a lot of hype with colorectal screening. So I will start there and then I will show you the data, how they are. Especially in the United States, this has been touted for many, many years. It started with President Reagan because he had a colonoscopy back in the 80s and he was diagnosed with colon cancer. And after that, everybody wanted a colonoscopy in the United States. It was promoted by many, many organizations. So now about 65% of all people in the US are regularly screened, and most of them is colonoscopy. And now they just reduced the screening age to 45 years. It was 50 before. And they recommend that every 10 years. In Europe, in Australia and other countries, we usually don't do that, except in Germany, Austria, and previously in Poland. We do fit screening, many of us, every other year for a number of years. Most countries start a little later than the Americans, 50, 55, 60 years, and go until 69, 75, 70, 79, depending. Again, it depends because the evidence is so difficult to read and sometimes not there. before the new evidence arrived a couple of years ago, we, the world, the Americans especially, thought that colonoscopy would be enormously effective. So this is old data from the New England Journal. This is observational data, which indicated that colonoscopy can reduce colorectal cancer incidence, the risk, by 50%, and death of colorectal cancer by 70%, 50 to 70% with one colonoscopy. Think about it. Think about how many therapies in medicine can do that. Colonoscopy can do it, people thought. Here, a very famous study also from the New England Journal saying the same thing, 53 to 90% risk reduction. Modeling said the same, 30 to 90% risk reduction with colonoscopy. Then we published this paper in the New England Journal of Medicine, and this is one of the things you asked me for to talk about. That's why I'm talking about it. And it created a lot of attention. And I will tell you why. So this is the first randomized trial. And as you know, randomized trials, we like to do that in medicine because it gives us the best evidence for, the question, does this work? And how much, if it works? Because we want to know the risk and then the contribution of an examination or intervention to reduce that risk, just like with hypertension or heart attack. I was around for many, many months and was doing podcasts and webinars and shows and TV sessions after the study because everybody wanted to discuss it. It created a lot of headache, especially in the United States, not so much in Europe, but also in Europe. So the trial is called Nordic. It's a relatively simple design trial. It's a randomized trial with 2 arms in these 4 countries in Europe, where about almost 100,000 people, not patients, people, healthy people, at least as far as we knew, walking around on the street in this age group, 55 to 64 years, around 60 years. They were randomized directly from the population registry. So we did not go to you guys, to the GPs, to ask for lists or anything, or for interest. We went directly to the population registries, and we told the population registries, give us the list of everybody who lives here. And then divide into 2, and we randomized half or 1/3 of them to a colonoscopy, 1 colonoscopy, and the other to nothing. And nothing was what was done in the areas where we did the trial. So there was no screening program going on. That was important to us because we wanted that control group. And the primary endpoints are, as we talked about, the important stuff: incidence of cancer and mortality of cancer. So for that paper in the New England Journal, for reasons that we can discuss later, and I can tell you more about this, it's an own story. We did not get data from the Netherlands for this first analysis. We only got them for the other 3 countries. So it was about 85,000 patients, or people. Sorry, they're not patients. And these are the different countries. So most of them from Norway and Poland, and a few from Sweden. And they were both men and women. This is the participation rate, because as you can imagine, you just ask people on the street, would you like a colonoscopy? Not everybody says yes. And we didn't think that everybody would say yes either. So the participation overall was 42%. It was much higher in Norway, 61%, and lower in Poland and Sweden, as you can see. And we can discuss why that was. We had good bowel preparation, and our endoscopists were good. They were coming all the way up to the cecum in most of the patients, and they were finding adenomas, so polyps, just as we expected. And we didn't have much complications, which is great. And importantly, and this was one of the things that our American friends, or my American friends at least, did not believe, we did not have colonoscopies in the control, which is unthinkable in the United States because everybody gets one. But of course, as you know, in many European countries, that's not the case. And here are the results for incidence of colorectal cancer. And you can see the risk. If you look at the the risk first. The risk is low. So the risk in the people who get nothing is 1.2% after 10 years. So the risk of getting colorectal cancer if you do nothing, that's that number one thing there I told you that you should discuss with people, is 1.2%. And if you then are randomized to colonoscopy, it goes down to 0.98%. So it goes down by 0.22%. These were everybody who was randomized. That's how you do randomized trials. You randomize and then you compare the people randomized to one arm to the other. That's the unbiased analysis of a randomized trial in medicine in general. But we also looked at only the people who showed up, the 42%. There, again, the risk in the folks who were not invited is 1.2%, and it goes down to 0.8% in the people who actually got screened. What about mortality? Short story, no difference. Very, very low risk, 0.3% after 10 years, and no difference between the group randomized to the one thing versus the other. But for the people who were actually screened, there's a reduction. Relative numbers, 50%, absolute numbers, very small, 0.3 to 0.15. I will come back to this. The all-cause death rate, that's the saves lives part. There was no difference. We hadn't really expected any, but these are the numbers. I will come back to that. There was a lot of criticism, mainly in the US, because I believe, because people were disappointed. Because for two reasons, I think they were disappointed. Number one, we focused on the absolute risk because that's how we think this should be communicated. Everything in medicine should be communicated. It's just not that spectacular if you talk about absolute risk than relative risks. And also the reductions were not as impressive as the modeling suggested. It was not 90, not 80, not even 70, maybe 50, but most likely 30. So this was back in 2022 and then into 2023 when we discussed these data. Then in March of this year, new evidence came. A little different, but very important. So the EUROPREV trial, which is the trial I will now show you in the next couple of slides, is a large randomized trial in Spain that did a very clever thing. I would have liked to do that also in the Nordic trial, but we didn't have the money. They included a fit arm. So they compared colonoscopy, which we did as well, to fit. They didn't have a no screening arm as we had, but they had a fit arm and the colonoscopy arm. So now suddenly you have a head-to-head comparison, randomized, high quality, of the two tests that we talk about all the time and that I talked about today. First trial has never been done before. They published this in the Lancet in March of this year, and my wife and I wrote the editorial. You can look it up. So a little smaller than the Nordic trial, but still very large. 26,000 patients or people in each group. Rather complicated design because people could cross over from one group to the other, and there were some other features there that make the results a little bit more complicated than the Nordic results. But I will take you through it very simply. Participation here was low in both groups, lower than in Nordic. You remember we had 40% overall for colonoscopy in Nordic and 60% in Norway. Here it's 20%. And even for fit, the first fit round, 33.6% showed up, but then you have to do this every other year. It's only one colonoscopy, but then 5 fit rounds. And for the 5th fit round, people get tired. Only 18% showed up. So here are the results. And first I show you the intention to treat. This is the left-hand side. These are the least biased. These are the trustworthy analysis in any randomized trial. The people who are randomized to the two arms, compare everybody. Here you can see, the first thing you see if you look at incidence first, ITT incidence, the upper left. What you see, the absolute risk there, 1.22% is exactly the same as in Nordic. So the risk of colorectal cancer in Spain, in Norway, in Poland, in Sweden is 1.2%. Quite remarkable. And then you reduce that risk a little bit, but not significantly different if you do a colonoscopy as compared to FIT. You can see the error bars there, that these are these shades. They're overlapping, which means there is no significant difference. The same for death down there. No significant difference. And again, 0.24%. Remember where we had 0.3% in Nordic, very similar, but no difference between FIT screening every other year and one colonoscopy. However, if you go to the other side, this is the pair protocol. So only the people who got screened with either of the tests. You can imagine that there is at least a trend for a superiority of colonoscopy, but it's not very large. It's at the border of being significant, and the rates are very low again, as in the other trial. So you can tweak this any way you like, I think. So what should we tell our patients then? FIT or colonoscopy or nothing for that matter? And I think it's just as I told you. We should discuss the risk of the disease with the person in front of you, and then discuss these numbers that I just showed you for the two. And I have a slide after this one where I summarize it, so you don't need to write it down. For the two options, if the two options are in your country or your region or your city, if there are FIT and colonoscopy and nothing, you give them the numbers for these two options. And you explain the burdens and the harms, and you all do all this in absolute numbers. And what are the numbers? Well, this is what I tell my patients or people who ask me really. I tell them that, well, if you live in Norway or Spain or Sweden or, Poland, and this is the same, pretty much the same in the other countries, your risk of getting colorectal cancer in next 10 years is about 1.2%. And I sometimes use the calculator because it's a little bit different, of course, as you get older, or if you smoke. Some people like lifetime risk. Then I say it's 4 to 5% because that's what it is. And then you can just subtract the effects that I just showed you from that risk. So if you like the 10-year risk, it's 1.2, then you just say, if you do FIT, it will stay at 1.2. It will stay at 1.2. You cannot expect a reduction in risk of getting cancer. If you choose colonoscopy, it goes from 1.2 to 1.8, or 0.8. And you can do the same for the death rate. I showed you the numbers. And then I would talk about the burdens. FIT is every other year. You have to have a colonoscopy if you're positive, but you can do it at home, blah, blah, blah. And if you choose colonoscopy, you have to go in, you have to do the bowel prep. It's not fun. It may be a little bit painful, or you get sedation and you cannot drive for the rest of the day, and you may take off from work. And it costs you money if you have to pay. And the harms, I explain them just in the way they are described there. They are small, but there are harms. And I will just tell them what they are: bleeding and perforation. There's no harms for FIT. It's all for the people who go from FIT to colonoscopy, obviously. Now, towards the end here, I'm coming back to the safe lives thing that you promoted. We looked at that for all screening tests a couple of years ago. And this is all randomized trial data. And because there are randomized trials for mammography, for FOBT, for Sigmo, for colo, for PSA, for lung, there's no randomized trials for cervical. That's why we didn't put up cervical or melanoma for that matter. But as you can see, for the top three, mammography and fecal screening, there's no effect of the length of life. And we put this up in days of life down there, as you can see. There is an effect, borderline significant, for sigmoidoscopy screening, about 90 days. Colonoscopy, as I just showed you, the only trial which was available was the Nordic trial, and there was no difference. PSA has no effect, and lung has no effect. significantly at least. And you would ask, how is this possible? It doesn't make sense. Well, yeah, on first sight, it maybe doesn't make sense, but I show you that it does make sense. So here's what I think, or we think happens. Obviously, some people have a benefit in length of life from screening. Some people who are diagnosed with an early cancer at mammography or with a large polyp at colonoscopy, they will live longer with screening than without screening. These are the people who are in that first arrow up here. They live longer. However, we know, I just showed you, for many of these, it is zero. That's the evidence. So because it's zero, it's blue down here, some people actually live shorter, have to live shorter if they go to screening. And we know that is happening because some people die from complications of the treatment. Nobody dies during a mammography or during a PSA test, but some people die from complications after a prostatectomy or from a pulmonary embolism after a surgery for breast cancer or colon cancer. Some people do. And they obviously have shortened their life after screening because they went to screening. And if the sum of the two, some gain, some lose, is zero, that explains the zero in general. So for your teaser, you can say that it saves lives, but it does for some, but it takes life from others. And in some, it's zero or very close to zero. So I think we all should be careful with that claim. So is it time to reconsider screening? You know, go from what the Americans said to over the guidelines to the new data from Nordic and from the Colorectal trial, and I showed you the numbers. Well, I think it's important to understand that there's not really much of a difference between a 30% difference and a 70% difference with the absolute risk numbers we are talking about. And I just showed them to you, about 1% over 10 years, for instance, and 0.3. Because the difference between a 30% relative difference and a 70% relative difference is only 0.7% absolute. And now I'm coming back to values and preferences. You can ask yourself, what is an important difference for colorectal cancer risk? And the BMJ guideline panel at the time asked all panelists, before they looked at the data, what is an important difference? How large should that effect be to recommend screening? And they said, well, it's around 0.5%, maybe 1%. So it's in that range that we talk about. After the panel saw the data, they didn't want to have anything to do with what they said before, which is interesting in itself. So my take on the whole thing is I think colorectal cancer screening should be offered. I think it's okay to have programs. I think the data here, and I didn't talk about this, at least not much. The data here that I just showed you are a lot better than for mammography and PSA. They're a lot better. So if you want screening, you should want this one, not the other ones, I think. But it's not a magic bullet, of course. And it's always with prevention and screening in particular. It's always a small line of benefits and harms and burdens. So it's always a preference-sensitive decision. And therefore, it's a shared decision-making situation, and therefore nudging or promotion or advertisement is not a good idea. And when a person is informed in a good way, like I showed you, and the person says no, we have to accept that. And this is what one of your colleagues also wrote in the BMJ a couple of years ago, Minna Johansson, who is a GP in Sweden. And I agree with her on that. So what's next? That's the last slide. this journey continues, and there will be more data. The Nordic trial and the Colorectal trial has showed their first data. We in Nordic continue our study. We're actually working on new data right now. They will be out somewhere next year. The Colorectal people continue. There are two more trials, one in Sweden, one in the US. They are forthcoming with their data in a couple of years. We have data that are coming, or at least we're analyzing them in 6 weeks about surveillance. We haven't talked about that, but the question, how often should people come back after they have an adenoma removed? Now, as you know, it's every 3 to 5 years. It kills everybody. It kills me and my friends who do colonoscopy. We have thousands of these people, tens of thousands. We don't know what to do with them. We don't have the capacity. And then, of course, the story about AI and quality continues, and new markers. And I haven't talked about that because it's not a relevant issue yet in Europe. New markers are coming. And then, Verla, I received the questions from you. Should we stop here and do these afterwards, or do you want to do these now?
No, I think I first want to thank you for your very interesting presentation. I think we can give an applause. Yes, okay, this works. Thank you very much. And I think we should first see if there are questions from the audience, and if they are all answered, and there is still some time left, we can go to my own questions. But
of course,
I really feel the need to clarify something. So of course you don't know me. I I added the teaser of Screening Saves Lives intentionally to attract people who do believe this. I know, of course, that it is not the case, but I thought about it. Should I write it? Should I not write it? But I knew about that the sigmoidoscopy, it just saves lives. So I thought,
yeah.
okay, I'm not lying.
No, I think it was very smart to do because it gives me an opportunity to talk about it and address it. So I thank you for it.
Okay.
I appreciate it.
Yes, so I saw some questions in the chat. I don't know, perhaps Carlos, would you like to ask the question yourself, or would you prefer me to paraphrase them?
Okay, as you wish.
Okay.
Thank you, Michael, for this fantastic presentation. It was really very, very interesting. My first question was, why do you consider fecal occult blood test as an early cancer screening test? I find it difficult to understand that the aim of POBT is to find invasive cancer.
Yeah, it's very simple because, most adenomas, so polyps, do not bleed, and therefore they cannot be detected by a fecal test that detects hemoglobin. So the sensitivity of FOBT or FIT test to detect adenomas is low because they don't bleed. That's why it's mainly early detection.
Okay, that's the
There's some larger
rationale.
adenomas that bleed, so there's some, but not all, most not. That's why it's an early detection test.
Okay, thank you.
And there are other questions, Carlos? You can.
I have, but I don't want to monopolize the discussion. So if any other colleague wants to do other questions, please feel free.
But I think you can continue.
Okay.
Please.
I was curious about the risk calculator that they used in the BMJ guideline. They consider a 3% risk threshold, and to people with an estimated 15 years risk of the colorectal cancer below 3%, no screening is recommended. So 3 questions. First, how to calculate the patient's risk, and then Verla already shared the calculator they used. And this brings me to another question. Are you aware if this risk calculator is validated for other populations than the UK? Then the second question, why 3%? How did they get to this threshold? And finally, if I understood well in your findings, and then also in the findings of the Spanish colleagues of the Spanish randomized control trial, the risk was 1.2%. So in those countries that you mentioned Denmark, Poland, and other countries. So it's below the 3% threshold, then no screen would be suggested according to that guideline. Or am I missing something?
Yeah, great questions. Perfect. Thank you. So let's start with the calculator. The Q cancer is only one. There's at least two more that I think are good, as good as these calculators can be. Q cancer is, as you say, a UK, and it's validated in the UK. I don't think it matters really, because both the absolute risks and the risk factors, you know, smoking and age, they are very similar across all the Western world. So I think me here in Norway, I use the UK calculator, and I think it's valid also for this country. There's one from the United States, gives you very similar estimates, a little higher for some of the risk factors, but very similar. So you can use any of these. The Q cancer is very easy. It's a very nice, simple interface, and not many things to put in. That's also why I like it. The question of why 3%, it's a very good question. So when we did this guideline back in 2017, 18, published in 19, we were wondering, we wanted to give these absolute risks, and we wanted to give a recommendation of a risk threshold. And nobody had ever done this before. And the panel was very, very nervous about it. And so we did all this work to understand how we could arrive at a risk. We asked patients in the UK. We had our own projects. Patients replied not, well, how should I put it? They replied emotionally. Not, their replies were not relevant for any of we couldn't use it. It was just all over the place, from 0 to 100. And when we discussed it in focus groups, it was still not a good answer. So we went back to the panel, and we had questionnaires and polls about this before we looked at the data. I mean, many of these people were content experts, not all. There were also GPs, there were patient representatives, but we had some who obviously knew or guessed what the data would be. What we tried to do this before, and we arrived at 3. We also looked at what the cardiologists have done, and maybe John can elaborate on that. The cardiologist did some work a couple of years earlier with regard to cardiovascular disease risk, and they said everything below 6% is not interesting to do anything. So we also looked at that, and we thought, okay, let's start at 6. And then we went down to 3 because we realized, 6, let's, as you elaborate, that's so high, nobody has that high risk, which would mean that nobody gets screening, which would mean we can just drop the whole thing, which was scary for people. So at the end, we arrived at 3. And as I told you during my talk, when we then applied the numbers from the model and from the evidence, then people got really scary and said, well, I didn't say that. And then we went back to the tapes and said, you said that. But they didn't want to say it anymore. We have one person who pulled out of the panel altogether because she didn't like it. She said, I cannot come home with this. So it's very interesting. People are getting very edgy and emotional about it.
Yes.
Yeah.
I understand.
Yeah. And then 1.2% in the trial versus 3%. Two things to say about this. Number one, the 3% is over 15 years, and obviously it's a cumulative risk, so it gets higher when you get older.
Okay.
So the trials give you a 10-year risk. The 3% is 15. I think I guess we will be at 3 years with the trials for 15 years also, maybe even a little higher, because the risk gets gets higher when you get older, disproportionately. But yeah, many of the people in the trial will be under the threshold. And, you know, for them, a no answer is as good as a yes answer, I guess. That's why I brought it up at the end of the talk. Yeah.
Thank you. Thank you. I believe John has a question, Verla.
Okay, thank you, Carlos. That's a photo of you when you were much younger. That appears. John, you also had a question?
Yeah, and first I would really like Michael I would really like to say thank you to Michael. To those at the audience, I know Michael really well, so that's why I'm talking to him as a friend. But thank
Absolutely.
you. We haven't met for the past year, and I really appreciate your update on your presentation. The things you're talking about, emotional thinking. I mean, we have done some research about that. And I think that if people are interested in this, they should read Tammy Hoffman and Crystal Maas, two systematic reviews on people's thoughts about benefits and harms in screening. And I think that tells a lot of the story. So we need researchers, physicians, lay people with a lot of expectations to cancer screening that the evidence does not give us. And the question I actually have to you is about the harms. I don't know if you know, but we have published now 3 papers related to a systematic review on physical harms of colorectal cancer screening. And we have used the PRISMA checklist. So we have also looked through all the observational studies. And what we find is our main conclusion is that the evidence around harms is so poor. It's such a bad quality. So I think one of the problems, besides that people cannot do rational thinking around this, so shared decision making might also be an illusion. I think one of the problems is that when we try to explain the benefits and the harms, the estimates we have for harms are probably underestimated. Have you done any thoughts about that in your trials and how we should get valid estimates of potential harms?
Yeah, thank you, John. I really appreciate it. No, I actually don't. I haven't seen your papers, so please send them to me or send me a link. I would really appreciate that. I'm sorry about that. Harms, yeah, I mean, it is difficult. But I think the data are getting better because we have 2 things. Number one, there are coming quite good data from the screening programs, obviously, that have been introduced. And I think their harm registration is quite good as compared to the older data, which mostly are case series from clinical practice. And also then we have collected both the Colorectal trial and we in Nordic have collected the harms that are the harms. Now we're talking mostly about bleedings and perforations. That's the 2 that are mostly related on the physical side for the examination itself. Personally, and maybe I'm biased there because I do a lot of colonoscopies, have done many 10,000 personally. I'm not too concerned about the harm side. I think if we have that quality challenge that I explained to you with regard to finding polyps, and that also it's a problem of skills, of technical skills of the people who do it, and they also translate to the harm side. If you're not good with doing a colonoscopy, you not only you're not finding the polyps, but also you have a higher risk of harms. But if you have good colonoscopists, then the harms, bleeding and perforation, they're very low, less than 1 in 1,000 for perforation. There are, at least with the way we do colonoscopy in many European countries where we don't give general anesthesia. Some countries do, France, for example. I find it it's impossible to perforate the colon if you don't use a lot of sedation. People will jump off the bench before you can go through the colon. So I think that harm is very, very small. There is harm, however, if you remove big polyps, then you get perforations. You go through the wall sometimes because you just dig into it to try to get the polyps out. But also that now, what we do now, usually 10 years ago, we would operate all these patients, send them to the surgeons, but now we just clip the hole and we just fix it. And it takes 5 minutes and it's okay and the people can go home. So although there are harms and they should not be neglected, I'm not too concerned about that side. I have to say, but again, then I'm a colonoscopist, so I'm biased.
And what we see in France and in Denmark in our quality databases is that around 1/3 of harms are reported only in the quality databases. And
That's interesting.
And we cannot have. I have put the two of the 3 papers links to that, and one has been accepted, but not published yet. But it's coming. So the 2 papers we have published are about all the potential physical harms, and then the 3rd paper that has been accepted is about, are those harms used in systematic reviews and guidelines?
Mm-hmm.
The conclusion is, of course, not.
No, of course.
They're not described.
Yeah.
But I totally agree with you when it's a university hospital where it's trained colonoscopists. The problem is that is not everyday life in screening programs, and we can see that less and less experienced clinicians, nurses, physicians are doing the colonoscopies. So my worry is that when you do randomized studies and when you do invasive scopies in university hospitals, the numbers are beautiful, like in your studies. However, in everyday life, it's different.
No, I agree. And there's 2 things you always need to do before you start any screening. Number 1, you have to fix quality challenges. You have to make sure that everybody is properly trained. That's so important. And number 2 is you have to make sure that there's good quality and access on the therapy side for the people who need surgery, chemo, etc. And if that's not fixed before you start, then you have big problems. For example, Germany has that big problem because all colorectal screening is done in small private practices, and was a political decision because there was a lot of lobbying at the time. And then you get a problem because you have 10,000 private practices doing colonoscopy, and you don't know how these people are trained and how their skills are, and then it gets dangerous.
And you don't know the quality.
Yeah.
So so in an ideal world with lots of resources, I mean, we can do this with some very small benefits and nearly no harm. However, if it's in everyday life where we have to prioritize, I think there's also this ecological and sustainable argument about how are we using our health resources.
Oh, I agree with you. Absolutely.
Yes, and I think adding to that, I think the question from Özden Hükdemir, if I pronounce the name properly. Would you like to ask your question yourself, or would you like me to paraphrase it?
Well, my question was about the COPC because not in every community has got the same problems in every place. So, for example, in my country, in some rural areas, people not saying that breast, it is chest, because it is much more naive for them to talk about it. So even that in that area, it is hard to make time for breast screening, for example. So if we say that, oh, the rates are higher in other, for example, Norway, so higher to get the real data about cancer prognosis, maybe we will lose people in rural areas that they didn't even reach to say breast or chest and to get to the real target for screening, although it is something for their community and it is something that's needed because they are out of data. It is just like the cat in the box. If it is really there or not, because they are not even on the site for that we are looking at the data. That's why I was asking that. Do we know the community? Do we know the screening tools? Because we are looking for the things that we have got as data. That's why I asked the question.
And what is your question? I don't think I understood your question.
The question was, if the community even couldn't reach the screening opportunity, how can we talk about the rates?
So you mean do you mean the rates for cancer if it's unknown, if you don't have good data for cancer risk?
Yes.
Ah, okay, I understand. Well, yes, that's a problem. If you don't have a good cancer registry or local one or national one, then you don't know what the cancer risk is in your country or your city or wherever you are. Yeah, you have to have that to make that kind of decision making. I know that all countries in the Western world report data for cancer incidence and cancer death to, for example, the WHO. But how good they are, that is different in each country. Many countries are very good, but others are not. And of course, that's something that you need to address locally and nationally.
And also migration just changed the data collection. Although in Turkey there is a good registry about cancer screening. So that's another problem. Migration is a real problem for this reason.
I agree.
Okay, thank you. Other people who have more questions for Professor Bretthauer? Yeah. Oh, John has a question, said that the problem about estimating the cancer risk is that in some cancers there are overdiagnoses. That was also one of my questions, I think. Is there what's the risk of overdiagnosis in colorectal cancer screening?
That's a very good question. And let me just say to John, I agree. I mean, once you get screening and at least early detection screening, it's very difficult to estimate the risk, the real risk, and tease out the overdiagnosis. I agree. Luckily, we have not been in that situation for colorectal because we have just been starting. But yes, it's a very well-known risk. It gets very messy to calculate the rates when everybody is exposed to screening, especially to early detection tests. How much overdiagnosis in colorectal? I think the honest answer is nobody knows. We have tried to estimate it. We're still trying. It's very difficult because when you have so I told you that we have preventive tests, colonoscopy, and early detection tests, FOBT and FIT. For the early detection, for the preventive test, it gets very difficult to estimate overdiagnosis because you have the part that detects the cancer, and there's always some that will drive the incidence up, and then the other one, which is the adenoma part, will drive the incidence down, and you don't really know what's the netto of these two are. It's very, very hard to calculate. And even for the FOBT, and especially when the programs are running for some years, you eventually get many people to colonoscopy because you have a positivity rate of maybe 5 or 6 or 10% each round, and that's cumulative. So when you have done that for 15 years, you have 35 or 50, even 50% of people going to colonoscopy who then are also exposed to the preventive screening part through the colonoscopy. So the calculation analytically, it's of overdiagnosis, it's very hard. It's much harder than with mammography or PSA screening. My guess would be it's lower than for PSA and mammography, but I don't really know.
Yeah, probably higher in the older age group, like for all.
Logically, yes.
Yeah. Okay. I see Carlos has another question. Yes, Carlos?
Yeah. What trends do you expect for the extension of the trial? Very good question. I don't know.
I'm making this question because I'm thinking about of the European PSA trial where we have seen some changes in the trends and in the balance between benefits and harms. Although the harms are still higher than the benefits, but there was some change. So what are you expecting?
Yeah, it's a very good question. I don't know. That's the fun part with being a researcher. You never know what you find out in the future.
Yes, it's true.
I don't know. I don't know.
Okay. But thank you anyway.
Yeah. So adding to that, what do you expect from further data? So I had also the question if we know already something about the morbidity. So not the morbidity in cancer incidence, which you showed, this is lower, but part of the morbidity are also the interventions.
Yeah. The therapy after, when you found, yes. Yeah, well, yeah. So the mainstay of treatment for colorectal cancer has always been surgery. And there is morbidity related to surgery. And then some of the folks need chemo and radiation, which is, of course, even more difficult and reduces quality of life. When you go to the preventive screening site colonoscopy, of course, for every cancer people do not get, there's zero morbidity related to that. If you take away the cancer, there's zero cost and zero morbidity, which is good. And then you have the early detection part. On that side, it is still, the mainstay is still surgery, and then for stage 3 and 4 adjuvant treatment. There's movement there in recent years, and we just started a big EU project on the goal here. The vision with this new EU project is to replace surgery for all, at least for all stage 1 and stage 2 cancers, with endoscopic treatment. So removing the tumor through the endoscope, through the colonoscope. There's some new devices that are now are coming, where you can basically just cut the tumor out with the endoscope during the colonoscopy, up to a certain size. This is not applicable to the largest tumors, but to many of the smaller ones. And many of the screening detected are small, relatively small, up to 2.5 centimeter in diameter. This is not possible today, but it has not been possible. We have randomized about 35 patients to one of the first trial here, so we know it's technically possible now. If it has the same oncological outcome, we don't know yet, because that's what the trial wants to find out. Because what you cannot do with these techniques, you can take out the tumor very easily. It takes 5 seconds. You just suck the tumor in, you staple it, it's gone. During the colonoscopy, no surgery, no nothing. What you cannot do, of course, is the lymph node resection. You cannot do a resection of the mesentery. What usually you do with surgery, you do a hemicolectomy and you take the whole thing with all the lymph nodes. Many times there are no lymph node metastases, but sometimes there are, and we can't do anything about that. So that's the question of the trial. Will there be worse oncological outcomes? But there's movement there, and I think the hypothesis of the trial that it's okay to do this endoscopically, so you can actually take away the surgery. For me, this is a development which is very similar to what we saw with open CABG surgery and PCI, and also heart valves 10, 15 years ago. We did a lot of open surgery, and now we do everything through the catheter, through the femoral artery, or the cardiologists do. And I think we're going the same way with colon cancer treatment. That's at least what I envision, which takes away the surgery for many of these patients, which will be great in terms of morbidity.
Yeah. So of course that's for those who have already a cancer, but if I understood it correctly, so you expect that in 25% of patients, there should be an adenoma detected and removed.
Yeah.
So, and what's the follow-up with these people? With these?
Yeah. Yeah, they usually, you know, and now we have this strategy, which is not really, there's not good evidence, but all guidelines say that, and I'm part of these panels. We just, you know how it is. You don't have evidence, sit around the table, you think, okay, you know, for patients who have one adenoma removed or two adenoma removed, when should they come back? Yeah, maybe 2 years, 3 years, 4 years, we don't really know. So now it's 3 years and 5 years, and then after 10 years. And we think it's too much, too many of these checkups, of these surveillance colonoscopies. That's our impression. We don't find much that these people who are coming back after 3 years or 5 years, given that there's good quality for the first one. So we have this large randomized trials, pan-European trial. Almost 60 hospitals are involved that have tested longer intervals, randomizing people to the 3 and the 5 or only 5, or randomize people to 3, 5, 10 or only 10. Very courageous trial. And that trial will have first results now in December. So I hope.
But now, if you follow the guidelines as they are, that means that 25% of your population that is randomized to the colonoscopy arm will
have to come back
every 3 years a new colonoscopy.
Yeah, every 3 or every 5 years, depending on how many polyps they have.
Yeah.
And as you can imagine, if you screen the whole country, that's a lot of people who have to do these colonoscopies.
Yeah.
Costs a lot of money, and you know, some endoscopy centers around Europe, they don't have time to do symptomatic patients anymore because they have all these checkups for the polyps. It drives people crazy.
Yeah. Okay. Any more questions from the audience? No.
May I ask one? Well, it is about the planetary health perspective. What do you think about the colon cancer rate and also about planetary health? Because the things that we are eating or we are breathing is not so well, the seeds even so. Can we say that this is a problem about not only heart attacks and also dementia, but also a problem for colon?
Yeah, I mean, Western lifestyle is associated with colon cancer risk. The two, well, age is a risk factor, but age is not a modifiable risk factor. So of the modifiable risk factors, smoking is the largest one, and then it's obesity. And then there's stuff like red meat and ultra-processed food where the data are not very good. And maybe it's just a matter of not so good data quality, or the association is not that strong. I don't know which of it is.
Thank you very much.
So, and adding to that, my question about the alarming messages that colorectal cancer incidence is rising, especially in the young people.
Yeah.
That's why the USPSTF has lowered the starting age, but then the American College of Physicians, Family Physicians, I guess, did not follow that. I think here in Europe there are different opinions.
Yeah, the European Union, actually, it's just out a couple of days ago. That it's on the website that there's only a couple of statements because the European Union is working on new colorectal cancer screening guidelines. And they just put out the first statements, and they said that they will not reduce the starting age in Europe. That's the recommendation. It will stay at 50, which I think is a good decision, because I think there is an increase for the people who are between 40 and 50, but again, on the absolute scale, it's so small. the risk, we talked about the risk of 1% over 10 years, that's 10 years. That's for the people who were 60 years. When you go down to 40, 45, you are at a risk of 0.01% over 10 years. And even if you double that risk to 0.02, it's still a very, very small risk.
Yes, indeed.
So I think I think it's smart not to reduce the start age, not with these low risks.
Okay. So I see that our guests, participants are slowly leaving. It's understandable because I think in Turkey it's 4 hours later than here. So a good night rest is very important for health. So thank you everyone for participating. Don't forget that we have another webinar coming the 19th of November about another form of screening for atrial fibrillation. Good night to all of you.